folks, welcome to iCubed episode number 44. This should be October 2020, so thank you so much for coming back and watching this month. I hope we have another terrific episode. I want to introduce my guest. Now, I don't think he needs any introduction at all. He's one of the most famous, well-known, and respected emergency medicine educators in the world, actually. And, you know, I started my academic career about 4 years ago after 20 plus years of clinical medicine. And I consider this the pinnacle of my academic career to have Dr. Amal Mattu as a guest on iCubed. Amal Mattu, can you believe it? Amal Mattu, yes. So he is...
You need to raise the bar, I think. Aspire for more than that.
He is a professor of emergency medicine at the University of Maryland School of Medicine. He is the vice chair of academic affairs at the University of Maryland College of Medicine. And he's the director of the Faculty Development Fellowship there. And lastly, he's a co-director of Emergency Cardiology Fellowship in the Department of Emergency Medicine at the University of Maryland. And therefore, I am super, ultra excited to have Dr. Amal Mattu as my guest. Welcome to iCubed, Dr. Mattu.
Thanks, Alice. It's great to be here. This has been a long time in coming. I know we've been planning this for quite a few months, and different things came up, and global pandemics and all kinds of things. So glad to be here.
Oh, what pandemic?
Right.
Well, anyway, I started this about 4 years ago at iCubed, and I remember having your encouragement to do it, so I really appreciate your encouragement.
Yeah, it's been going really great.
All right, Amal, I'm going to give you a challenging case.
Uh-oh.
So I go on shift. This is a Friday a few years ago, and I meet this nice lady. She's 48 years old. She's healthy, she says. She comes in with this crushing chest pain that morning, all right? She says she'd been having these episodes for about 8 days, just 8 days, never before. It usually happens in the morning. So during that week, she saw her PCP about 2 days before she came to me on Friday. She was told she had inverted T waves. Then, amazingly, she saw the cardiologist a day after that, the day before I saw her in the ER. And so then a coronary CTA was ordered for Friday, the day that I saw her in the ER. Okay, but she came in that day because she had the pain again, and it was so severe she couldn't wait to go to the angiogram. So she came to the emergency department. She said she was nauseous and she felt really lightheaded with the episode that day. But by the time she came to the ER, she had completely resolved her symptoms. Okay. She has a very minimal history, a little bit of anxiety and depression. She doesn't have any known major coronary artery risks, right? These are the classic ones: hypertension, diabetes, smoking, hyperlipidemia, family history. None of that. Social history: she's never smoked, and she does drink maybe one drink a day. Medicines that she's taking, just Buspar and Xanax as needed. So I go into a room and I meet her. She's really nice, very calm, nice lady, looks her age. Her blood pressure was 129/72. Heart rate was 54. Respirations are 15. Her room stats was 97%. All right, so this was the only hint I gave you. I sent this to you. What do you think?
Well, it looks like there's a sinus rhythm. Mm-hmm. The axis looks normal. I'm not seeing any overt signs of ST elevation or depression, but there are T-wave inversions that you referred to earlier, right. V1, V2, V3, and just kind of a hint of an abnormal T-wave in V4 as well. And so those are the main abnormalities that we're looking at.
Right. So I saw this and I thought, oh, well, she already had the inverted Ts. And I've seen, through my career, many of these types of inverted T-wave EKGs, and I didn't think a whole lot, but I definitely kept it in the back of my mind that this was not completely normal in someone who was very healthy, as she reported. All right. So what do you think we should do at this point, or what would you do? I mean, you have the physical, you've got the vitals, you've got that triage EKG. She's sitting there, she's pain-free now.
Yeah, well, the T-wave inversions are definitely concerning. And when you see T-wave inversions in V1, V2, V3, in somebody who's having any type of cardiopulmonary complaints, there's a couple of things that you need to think about. One, obviously, you think about cardiac ischemia. The other that you should think about also is pulmonary embolism. And other things that can give you flip T waves in V1, V2, V3, pretty much isolated to V1, V2, V3. You think about Brugada syndrome if it's a syncope patient, but there's really no right bundle type of pattern. A true right bundle can give you flip T waves there, but again, there's no right bundle pattern.
Right.
And then the one other thing to think about, say it was a syncope patient, is ARVC or arrhythmogenic right ventricular cardiomyopathy. That can flip your T waves in those leads as well. But again, this isn't really coming in like a syncope presentation.
Right. Yeah, honestly, I thought, well, there must be some kind of ischemia, maybe transiently. But she was so symptom-free and looked so fine and also had no medical history, really. Mm-hmm. I just kind of, was waiting just to see what the results of the testing would be. So for me at the time, my thoughts were the following. I mean, she was pain-free. She was supposed to get a CTA that day. She came in anyway. It was daytime hours, sometime between, I think it was 8 a.m, actually. And then that particularly the ER wasn't overly, overrun by patients. So I thought, all right, let's just do this very unusual thing, which is to order a coronary CTA. In the meantime, the troponin comes back. So I had time. I calculated her heart score. I thought her history was moderately suspicious. I mean, she was saying that it was a terrible crushing chest pain, right? So I give it a 1. The inverted T's, I thought, well, let's give her the 1. It's sort of non-specific. And then she was young. She was 48. Gave her 1 point. But she had no risk factors for coronary disease. The troponin came back negative. So I gave her a heart score of 3. Does that sound reasonable?
Yeah, I think so. It's pretty reasonable.
Yeah, I think so. So, things change in the ER, right? Sometimes you're better to be lucky than smart. But so the nurse calls me when the patient comes back from from the CT scanner, and the nurse goes, "She's having a lot of chest pain again." So I go into the room to look at her. She's a little bit pale, and she looks like she's really in a lot of pain. I mean, very different than when I first met her. So I ordered a repeat EKG, and then I asked for nitro to see if that would help or not. I mean, because in my head, is this GI, is this cardiac? I mean, is it anxiety, panic attack? What's going on with this lady, right? This is the repeat EKG when she was having pain.
So it's the T waves are certainly looking worse. They're deeper than they were during the initial 12 lead.
Right.
And there's no other abnormalities that I'm seeing that have surfaced. Maybe a little bit of some T-wave flattening out there in V6.
Right. But, so I put the two of them together, and that's exactly what I noticed. When she came back with that pain and the repeat EKG was done, I thought, oh, geez, that is a definite change. That T-wave is deeper and more alarming. And that nitro took away her chest pain. It just wiped it away completely. All right, so Amal, the coronary CTA result came back soon after that. And it was a negative coronary CTA with a calcium score of 0. What do you think?
So that's very helpful in terms of pushing you even further away from cardiac ischemia, but that still leaves one big dangerous entity on the table, and that is pulmonary embolism.
Right.
And that really needs to be evaluated.
Right. I agree with you. Although that day, clearly I didn't think of that because I didn't order a CTA for PE rollout. Now, in this lady, when this came back, I was actually baffled. But at the same time, I was also relieved simultaneously. Nonetheless, I thought about her ED course, and I thought, there is no way I'm sending this lady home. She had severe pain, which resolved, and then had severe pain again, which had simultaneously worsening EKG changes that concerned me. And so clinically, my gut was like, there's no way this lady's going home. I don't know what's going on, but she needs to come in. So I called a cardiologist, and we got her put in the observation area, which we have. All Alrighty, so everyone knows that I have two learning focuses, and the very first one is actually what this EKG reflects. You want to guess? It's Wellens. And I will confess, I really didn't know much about Wellens at the time, but now you guys and I, and Dr. Mattu will talk about Wellens, all right? So I have, always used lots of blogs to help me do research for these episodes, and these are three I've read recently as well as before. So Rebel EM with Sal Orzai. I've also looked up in Life in the Fast Lane. And then I did find this a terrific article called Wellens Syndrome, a Historical Literature Review. Wellens Syndrome, and Dr. Mattu, please do jump in.
Sure.
Yeah. So Wellens Syndrome is a pattern of deeply inverted or biphasic T waves in V2 and V3. Okay? It is highly specific for critical LAD stenosis. The patients may be pain-free at the time of the EKG. The troponin may be negative or minimally elevated. The significance of Wellens is these patients are at high risk for extensive anterior MI within days to weeks, and usually requires invasive therapy. So this lady had Wellens. That's what her EKG was actually reflecting. So from the Life in the Fast Lane, there's an illustration of the two types of Wellens, right? There's the type A, which has the biphasic pattern, T wave, and then the type B, which is a deeply inverted T waves. Type A is about 25% of them, and then type B is 75% of the Wellens pattern. And there are examples, as you see, example 1, the T wave is biphasic, is a type A. And then again, example 2 is another really good example of a biphasic T wave. And then a type B, which is what my patient had, is a deeply inverted symmetrical T wave. Yeah. Now this is an interesting example. This is a type A, the biphasic, example 4. But the next EKG there on the right bottom was this patient's pre-hospital EKG, and it showed a clear STEMI. But by the time the patient got to the ER and got the ER EKG, it had become a pattern, a type A. So in terms of differential diagnosis, the inverted T waves, and Dr. Mattu already talked about for differentials early on. So subarachnoid hemorrhage can cause the inverted T waves. Pericarditis can cause inverted T waves. PE, again, one of the top differentials Amal talked about. Takotsubo's cardiomyopathy can cause inverted T waves. I did a case of Takotsubo's with one of my cardiologists a couple episodes ago. Electrolyte abnormalities could cause inverted T waves. Hypertrophic obstructive cardiomyopathy can also do it, which I didn't know. And then pancreatitis can cause inverted T waves.
Now, in terms of that differential, the good thing about the differential, the bad thing is that it's a big differential, but the good thing about the distribution of the T waves is that if we're only talking about T wave inversions in V1, V2, V3, then a handful of those things fall off. It's really unlikely that subarachnoid or pericarditis or Takotsubo or electrolyte abnormalities or HOCM or pancreatitis would give you T wave inversions isolated to V1, V2, V3. So that really does point towards PE or anteroseptal ischemia, and then the few other things, the Brugada, the right bundle, and then the ARVC.
I think that's a great pearl.
Yeah, it narrows the differential.
Yeah, I think that's a great pearl, that the Wellens is much more isolated inverted T waves than diffuse, yeah. All right, so then in the Jacobi Emergency Medicine Residency post, they put down these take-home points with regard to Wellens, okay? There is no modern data on the prognosis of Wellens syndrome treated with dual antiplatelet therapy and heparin. So medical treatment is not proven really to help. The Wellens EKG pattern in patients admitted for unstable angina is specific for a significant proximal LAD lesion. This pattern must be found when the patient is not having active chest pain, and the patient should report a story concerning for unstable angina, which is so true with my patient. be mindful of the differentials of the anterior T wave inversion, and remember that Wellens syndrome should not have Q waves or widened QRS. Although not a STEMI equivalent, the Wellens pattern represents an impending MI within days to weeks. That's a very critical point for Wellens, picking up Wellens. By identifying Wellens syndrome, you have increased your pre-test probability that medical management will ultimately fail in preventing an MI. A very rough estimate of the number needed to treat Wellens syndrome patients with revascularization to prevent an MI is only 2. Wow, that is quite an impressive NNT. And then Wellens is likely a reperfusion pattern, and we saw that in that example of the pre-hospital STEMI EKG monitor and then the Wellens in the emergency department. All right, anything to add to that, Dr. Mattu?
Well, the Wellens can be a reperfusion pattern after the patient with the STEMI has reperfused, but it can also, and I would guess the majority of times when patients come in, it's not a sign that they are reperfusing or getting better. It's something that needs to be worked up. Now, what's unusual in this case is that if this is Wellens and the patient has a big proximal LAD occlusion, the coronary CTA should have been positive, because with the LAD, the coronary CTA should almost certainly pick up an LAD occlusion. The coronary CTA, when the angiogram part is done, it's very, very good at picking up occlusions in large vessels. For example, the left main, the LAD, and RCA, left circumflex. And if we're talking about true Wellens, you're talking about a significant or critical occlusion in a big vessel. So I think it would be almost unheard of for the CT angiogram of the coronaries to end up being negative. Now, on the other hand, if it was just a calcium score that was done and not the angiogram, it is possible for the calcium score to give you kind of a false negative. Not that common, but it's possible if it's a young person who does not have calcified plaques yet. But if the dye was squirted, if you squirt the dye, you really, really ought to see a critical occlusion in the proximal LAD, which is what your Wellens is suggesting. And so that's why even after that negative coronary CTA, my thought about this case leaned more towards PE, because I just can't imagine a patient with true Wellens with a critical occlusion in the proximal LAD would have a negative CT angiogram of the coronaries.
That's fantastic, Amal. I'm going to tell you, this lady had a slightly elevated trope later on that same day. So they decided to take her to the cath lab that Friday afternoon, and she had a 99% LAD occlusion, stenosis, and they stented her. So the cardiologist went back to the radiologist, and they went through the coronary CTA together, and the radiologist saw that he had misread the coronary CTA.
Mm. Yeah, that's not surprising then. Yeah.
That you totally knew.
If that patient's in your emergency department and they get a negative coronary CTA, then that diagnosis is almost excluded, and you would have to think about a PE. I would have sent that person now for a CT pulmonary angiogram.
Right. But I wanted to let you know, just as a colleague, I felt very uncomfortable with the lady once she had those EKG changes, and the you look at the patient. I'm a clinician through and through, okay? And when I went, again, I'm not even kidding. Sometimes you're better lucky than smart. Mm-hmm. When I went back to see her, because she's had pain again in the ER. I don't know what I would have done if she had no pain, but she had pain again, and I repeated EKG. I looked at her, and she looked different. She looked like she was really sincerely in a lot of pain. Mm. And I thought, okay, well, this is not, not something, slight. And then the fact that the EKG got worse and the fact that the nitro took away her pain really supported my gut. I'm like, okay, this is probably clinical gestalt, but I just said, there's no way she's going home. There's absolutely no way. We got to figure it out. We don't know what it is, but there's no way. So the next day I The next day I found out she had a 99% occlusion. I was like, oh my gosh, I'm so happy I didn't send her home.
It just goes to show that you've got to trust your gut and that you can't always rely on the test interpretations or results.
Exactly. All right, so learning focus number 2. Guess what it is? Just a brief word on CT coronary angiogram. Does this look familiar, Dr. Mattu?
It does vaguely, yeah.
So Dr. Mattu has been so influential in my career as a clinician. And so I'm constantly looking at his prolific postings and his podcast and listening to him faithfully. But Dr. Mattu does these articles up on Medscape, and this one was terrific. 3 must-read emergency medicine articles from 2018, one of which was this one, Clinical Policy of ACEP regarding critical issues in the evaluation and management of emergency department patients with suspected non-STEMI or non-ST elevation acute coronary syndromes. And so, Amal, you can expand, but Dr. Mattu said the American College of Emergency Physicians Clinical Policy Subcommittee stepped up to address this challenge and has indicated that in its clinical policy that after a patient has been ruled out for an MI, if the patient's risk for ACS is less than 2%, there is likely to be greater harm than benefit by mandating further provocative stress testing or coronary CT angiogram. So how do you know, is there any way to know if your patient has less than 2% chance of ACS? Well, there is. And again, Dr. Mattu is so influential in teaching legions of emergency medicine physicians. The heart score has been validated, and that's what I use for this lady. And the warning, though, I have is you can't just rely on your heart score only. You can't just rely on your coronary CT angiogram only. You really need to put the data along with a live person in front of you. And that's clinical gestalt, if you will. I remember one of the essentials, I think, and I can't remember which ED educated talk, but there was a talk within the past 5 years at Essentials or Resus that was talking about, don't overly rely on the heart score.
Yeah, so I think it's important to remember that many of these scores that are used, the heart score and the PERC score and many of these other scores, these are really not intended to be used in every single patient that shows up. If a patient comes in and this is a no-brainer STEMI, you're not going to use the heart score. You're just going to admit them. If somebody comes in and they're complaining of pain on their chest right where they got punched and there's nothing else, you're not going to use the heart score. That's just silly. You might end up admitting people who don't need to be admitted or sending home people that shouldn't be sent home. So these are not intended for no-brainers. These are intended for the people that you have a little bit of equivocation about. And that's what the heart score really should be used for as well when deciding about whether somebody should be sent home. You'll notice in the EKG score, they give 1 point for non-specific repolarization abnormality. And what I would argue in this patient, that the patient didn't have non-specific EKG abnormality. The patient had clear ischemia. Non-specific is like T-wave flattening and that kind of junk. This patient in our emergency department, we would not even use the heart score because this patient has a no-brainer ischemic EKG. Similarly, the heart score uses troponins and you get 0. If your troponin is a little bit elevated, you might get 1 point. If your troponin is majorly elevated, you get 2 points. And theoretically, you could have a heart score of 2 or 3 with a clearly positive troponin. Well, you'd have to be an idiot to send somebody like that home. So again, this is not intended to be used for the no-brainers. And I would say that in our emergency department, 0% of my faculty colleagues would use the heart score for this patient because this patient has, number one, a clearly positive EKG, and number two, we usually use the heart pathway, which incorporates a second EKG and a second troponin. If there's any evolving changes on the repeat EKG, you're done. You don't use a heart score if there's evolving changes. And you demonstrated that there's changes on that second EKG. So the heart score gets thrown out the window. This patient's an automatic admission. So I would not look at this patient as having a heart score of 3. I would look at this patient as heart score is not appropriate to be used in this patient. This is an automatic admission.
That's
so
fantastic.
I think people need to be careful. People need to be careful about overusing these scores. These are only meant to be used for equivocal cases when you don't know what to do. But if it's a no-brainer, then just bring them in or just send them home. Don't use scores for those cases.
That's fantastic. That's really great teaching. At first, as the case progressed, I naturally used the heart score because I really didn't know what was going on, right? I had 1 EKG, I didn't have a trope, and I just was kind of assessing what risk she really had. But yeah, absolutely right. It became a no-brainer. Once the EKG became more ischemic, I thought, oh, geez.
Yeah, that repeat EKG is a slam dunk to just bring them in and don't even bother using scores.
That's great. All right. Well, folks, that was quite a learning case for me, quite a challenging. And I think the fact that I've been a clinician for so long really helped me. I really truly believe in this entity called the clinical gestalt, and I think the experienced physicians have that and really gets them out of trouble a lot. So I hope you guys learned something this month, Wellens, and then the CTA angiogram. And I am absolutely delighted, Amal, that you came and joined me today. I am so honored, and thank you so much for spending your time. I know you're very, very busy, so I really, truly appreciate your time with me.
Alice, it was my honor. I really enjoyed the time. Thanks.
Wonderful. All right, folks, stay safe. Please don't be weary of wearing your PPE. It's so important. Please protect yourself. Keep yourself healthy so that you can serve others in your community, okay? All right. We'll see you next month. Bye. Bye, Amal.
Take care.